morning and greetings from AIMS-Mangalagiri. We are a central government autonomous institute located in located in Guntur, Andhra Pradesh, and we've got a wonderful campus that's located between the two hills of Mangalagiri. Mangal means auspicious and Giri means hill. So as you can see, a beautiful campus located between these hills, and it's a beautiful place. And I would really welcome anybody interested in coming and visiting our institute and our department. At the outset, I would like to thank the organizers for inviting me for this talk, and I'm really sorry for not being able to attend physically because of my health, and also that my leaves could not be sanctioned, so therefore I'm really sorry for not being able to attend physically. So I would like to start this talk by giving a disclaimer that this is a non-scientific talk. It's got more of philosophical angles because this involves a lot of self-introspection and a lot of behavioral changes are required from us for the implementation of the successful and a sustainable antimicrobial program. And it's more of an attitudinal problem, not an infrastructural problem, or not a administrative problem, or not the fact that I don't have automation, so I can't do antimicrobial stewardship, stuff like that. Antimicrobial stewardship can, and I have done it in the absence of automation also. So, like I said, the human behavior has got a lot of intrinsic and acquired entities. So what are these? This is our consciousness, our chetana, our intellect, which is our buddhi, our ego, that this is me, I am doing it, I have said it, you have to do it. Our mind, that is very, very volatile. Awareness of being, that is our chit. Our conscience, our antaratma, how we are able to introspect and tell ourselves that what is right and what is wrong. What is our will? Our emotions and our expectations. So, ego, emotions, expectations, they drive all our karma, and unfortunately, they are the ones which hinder the implementation of good practices like antimicrobial. So, if we talk about what is dharma, the right of the action of righteousness, that is, in case of doctors, it is patient care, patient safety, safe healthcare practices, prevention and development and spread of AMR, good lab practices, good clinical practices, hospital infection prevention and control. All these aspects are the acts of righteousness for patient care which can be implemented through 7 core elements of CDC, which is the leadership commitment, the accountability, drug expertise, action taken, the tracking, the reporting, and the education. So all these are the aspects by which we can implement the antimicrobial practices, and therefore, by the law of logical derivation, we say that dharma is basically the implementation of the antimicrobial practices that we all need to do, and if we are not doing it, that means it is adharma. So it is biological. It says that we have to implement antimicrobial practices irrespective of whatever situation condition that we are working in. So there are few questions of non-self introspection that we must think about, that how many postgraduates take up microbiology as a first choice. So there is a major issue that let's face it, that many of us are not taking it as a first choice. My own case, I wanted ophthalmology as a first choice, but then many of us just settle down. I'm using the word settle down, and therefore they are not able to give it that level of dedication and devotion that is they would have given to their first choice. So it's not that true say that many of the things people think that it's not a clinical branch, and many of think it's a light branch, and I'm saying it openly that there are family pressures on women. They think that pick up a light branch, pick up a lab-based branch. If you're a light branch, you can manage your family, you can manage children, light branch, like that thing. It is a fact. They do not shy away from it, and there are very few faculty who actually feel proud to be clinical microbiologists, and there are many of the MD microbiologists who always have this dream of donning a stethoscope around the neck and then going to the wards and looking at patients. So many of them they dream, okay, after my MD microbiology, I'll do a DM in infectious diseases, and then I'll treat the patients of dengue, I'll treat the patients of pneumonia, I'll treat the patients of HIV. So that is what is happening right now, because the mandate of the DM is also not very clear because they don't realize that they are the bridge between the lab and the clinics rather than them themselves in the clinic. So they dissociate away from the lab and they go towards the clinic rather than the being the bridge between the labs and the clinic. So that's one major issue about the behavioral changes. So I'll just give an example of an MSSA report that I encountered recently, and this person, the signatory authority, is an MD microbiologist who is reporting beta-lactam drugs like this which have got no MIC, they've got no breakpoint, and they're reporting it in MSSA isolate. And also the third generation cephalosporin, they're reporting drugs like Piptazo for MSSA, and also unfortunately glycoside also being reported for MSSA despite the fact that glycoside are not to be used for MSSA isolate. So when I discussed this particular report with one of my colleagues, so this is what he said on WhatsApp also, that most students who are coming to microbiology don't take this as a first choice. That's a fact. This is what I said in the initial slide also. So there's no attachment to the subject, there's no inclination to the subject, there's no love for the subject, there's no, you can say, madness, or there's no fervor, there's no dedication, devotion for the subject. And unfortunately, there is a faculty, they're also the historical reflection of the same picture. Because many of them who are faculty right now, for example, I would say in my case, for example, there are many people who are my contemporaries who are not interested in, they still believe light branch, and they're not as devoted and dedicated as they should be for the particular subject. So they're not inclined to teach. And those who are actually, hardworking, many of them, they are into only publication. For time to teach, they're in their rooms, they're writing papers, they're writing publications because they think that publication is the criteria for competence of a faculty. So that is a true picture, and let us not shy away from it. It's a blatant truth. If you want to change things, if you really want to have some impact of this particular talk and the implementation, we should first learn to accept the truth. So there are a lot of challenges in implementing the AMS programs. Like for example, the physician factors, physician is often fearful of litigation. If I don't give an antibiotic, the patient will put a case on me that you don't give an antibiotic. There are numerous promotions by pharma companies, like every pharma company will start combining clavulanic acid-based combinations with the cephalosporins and they will start promoting those drugs. There's competition among the doctors and time constraints. There's often no champion. There's no passionate clinical microbiologist who can actually look at the situation in these eyes, and they can discuss the case with them. They don't have that confidence because they have taken feedback, they have wasted their individual degrees, they often think that they're lab people. They're not clinical microbiologists themselves. There's often a poor interdepartmental coordination, and there's no lab support, and there's no availability of the antibiogram. These are major issues from the physician, and of course there are numerous patient factors also. Like the father of a patient, they will come to the doctor and they say that why don't you give me an antibiotic, please give me an antibiotic, they can actually earn the antibiotic, and they think that the greater the number of drugs that the doctor is writing, the better it's used. So there are a lot of wrong perceptions on the part of the physicians, on the part of the patients, and of course the commercial factors like antimicrobials are a major source of income for the hospital. So there are drugs like cephalosporin, for which there are no breakpoint MICs available, there are no breakpoint zones available, but yet they are being used. There are a lot of drugs which have been combined with clavulanic acid, a lot of drugs which have been combined with tazobactam, and they are being used in the hospitals because there are a lot of promotional activities from companies. Freebies are given to the doctors, a lot of holidays are given, a lot of so these are things which we know, but we are often shying away from. So there are a lot of issues that happen, like there's often lack of trust between doctors and patients because they think that this doctor is not providing enough antibiotics, is not a good doctor. And certain clinicians also, they feel that it's kind of a spinal reflex for them. It's like a knee-jerk reflex. So the moment they are soft, they start writing augmentin. They start writing drugs like amoxiclav and cefpodoxime and azithromycin if there is a viral urine. So all these things and promotional activities, all these things they create antibiotic resistance, and that it becomes a vicious cycle. So there are numerous challenges when it comes to implementation of the stewardship. Like for example, there is lack of inter-departmental coordination. Many of the pharmacology and the microbiology departments, they don't coordinate with each other for antimicrobial stewardship. Microbiology is not coordinating with clinical departments or AMS. There are minimal supporting facilities. For example, the administration also never feels the need or the urge to support microbiology in the sense that when it comes to provision of space, despite the fact that we have faced such a major pandemic of COVID, even after that, many of the microbiology facilities are not being given that important the way it should be given. And there's poor enforcement of regulations. Like for example, NMC came up with the regulation of the implementation of the Antimicrobial Stewardship Committee, which is from 15th of February 2022. So still many microbiologists, they may not have formed, or it is only on paper, but there is no actual functionality. Then there is no antibiogram being provided by department because there is no digitalization of the record. So if you don't digitalize your AMR data, in that case, provision of an antibiogram becomes very, very difficult because digitalization is very critical if you want to have stratified antibiogram. So that's the first requirement for any antibiogram tool generator is to have digitalization of the data. Also, of course, there is that who will give a better service, and there is an absence of a champion. Champion is a person who will spearhead the antimicrobial stewardship program and who will compel everybody to participate in all the aspects of stewardship, antimicrobial stewardship, hospital infection prevention and control stewardship, or the community stewardship. So there are a lot of issues when it comes to challenges with implementation. And like I said, there is often the lack of a universal antibiotic policy, so that has to be formed based on your antibiogram data. We must have our own local. So be vocal about local. We have to have our own antibiotic policy. All the departments need to have a collective responsibility for the implementation of the AIMS program and incentives. Like for example, in our case, we don't have any incentive from central government or any other governments or any other states because the agencies who are funding these incentives, they are siphoning these funds to specific agencies only. And despite doing a good job in AMR and AST, many times because of conflict of interest, or you can say your good relationships with certain people, only few people get favored and all of us don't get those incentives. Availability of the culture facility, because culture facilities in microbiology, automation is not the same as autoanalysis. It's very, very different from pathology and microbiology. We don't put a sample inside a machine and get the result. There's a lot of involvement of the microbiology knowledge for AMR, AMSP, how the antibiotics behave in different areas in the body in different patients. So that culture facility is often not available. Even if it is there, like I showed in the report, there's often a lot of wrong practices which have been done by microbiologists themselves because they don't know what to do and what not to do. There is no robust feedback system, and there is often a lack of what I can say the involvement of the community. You can say the community and family medicine department. The CFM department has to be involved in the implementation of the community stewardship for the prevention of the over-the-counter use of antimicrobials. That is one place where the community stewardship has to be involved by the department. So I worked in six communities so far. Like in Delhi State Government Medical College, there was zero accountability. The lab was almost half of 1 kilometer away from the actual patient care. So the sample transportation, that is a major issue. Report dispatch, report, and if you want to discuss the case with the clinician, that is also a very, very difficult thing to do. So one thing is that the lab has to be inside the hospital, next to the patient care, not in a medical college. Please, this is if any administrator is looking or is watching my lecture, please keep in mind that the microbiology facility has to be inside the hospital, next to patient care area. I also worked in a state autonomous medical institute where we did have a concept of antimicrobial stewardship and infectious diseases, but there was no leadership, there was no single focal point of contact who could say that this person is the nodal officer. Central Government University also I worked where there was no initiative, even though the lab and the hospital were quite next to each other, but there was no specific leadership and there was no vision. In a central government institute where we have the implementation of the dynamic HR career progression, where the concept is that we take care of the patients, we take care of the promotion. So unfortunately, there's zero accountability because people will get promoted on their own without doing any work. Unfortunately, and that's what we say that in some places, gade gode sab barabar hai. There is zero accountability, despite the fact that government gives you a lot of options in doing pure patient care work and focusing more on patient care rather than focusing on complications and projects and all those things. When I came to a state autonomous pediatric institute, I did have the know-how. There was partial automation was there, but there was poor leadership because the leader used to tell me that why are you doing reporting at night? Why do you come at night to do the reporting? I told that please give it to me in writing that it's not an emergency, and that person could not do that. So I was doing holiday reporting, I was doing night reporting, I was doing the turnaround time for blood culture reports to almost 24 hours or less because there was partial automation was there. I had the automated ID and AST machines with me, and I was doing things on my own, so I was able to implement those things. When I came to AIMS-Mangalagiri, it was the most congenial and most suitable environment for me to work, in the sense that the director was very supportive. We did have an accountability for the implementation of the antimicrobial stewardship program. Being the head of the department, I was able to spearhead the AMS program and be the focal nodal point for AMR and AST. And yes, we do have a antimicrobial stewardship team where we have the clinical microbiology. We've got 2 to 3 clinical microbiologists, 1 pharmacology faculty, 1 pharmacist we've got, and we do have the support of the hospital administration department, in the sense that the pharmacy DMS of the pharmacy is also involved in the antimicrobial stewardship committee. The state medical college I have never worked, but the issues that I have witnessed is that there are frequent transfers of the faculty. So there is no ownership. Even if somebody wants to develop something, they know that 3 years, 4 years, 5 years down the line they're going to get transferred, so they don't initiate something, or even if they initiate, they're not able to sustain it. And plus, there is the issue of private practice also involved in medical colleges. So, how to overcome these incumbencies is to take the lead, and if possible, only to believe in the cause of AMS. For that, you have to believe that that clinical microbiology is a great branch. Yes, I firmly believe in that. And once you have that kind of dedication, devotion for your subject, you do get a positive feedback from the clinician. That is a major positive reinforcement for us. And you have to aim small and live small. Don't try to implement all the 7 parameters of the antimicrobial stewardship program. The easiest thing is to start with education. Discuss the cases with them, educate them, read yourself. Implementation of the core elements, one small baby step at a time. Convince the administration, convince the clinician by setting an example. Make the clinical microbiology diagnostic services available 24/7. Try and get as much automation as possible, but please remember that antimicrobial stewardship is possible in the absence of automation as well. So, how did I overcome incumbencies was that when I joined the institute, in 1 month's time only I formed the antimicrobial committee with the director as the chairman, because I knew that in the leadership, the director has to be there, he has to be the leader, he has to spearhead the program, he has to be convinced that antimicrobial stewardship is the only way ahead. Then we had the regular AMR data maintenance on WHONET to digitalize the entire data on WHONET by creating an yearly antibiogram, doing the Sunday and holiday reporting with critical alerts and multiple tier reporting. In the sense that now we have a automated bacterial culture system, so the moment it flashes positive, the first step is to report to the clinician whether it's a gram positive or a gram negative. Next step is to do the rapid ID and AST. Rapid ID, we are doing the multi-top that we acquired in February 2024. It's the first tabletop multi-top, the combined state of Andhra and Telangana with the latest software. What we were told that we had identified a case of Burkholderia pseudomyeliae in vitro diagnostic mode of the Vitek MS, which was done for the first time in our country, because before that it was being identified only in the research only mode. And we are also doing 24/7 lab is open. Lab is open 24/7. We are doing Sunday and holiday reporting also. In auditing of all IBD culture positive cases, and the audit also, the consumption audit is also been done for IBD cases. The next is to implement the SAP and the antimicroprophylaxis guidelines. So there are 10 fundamental sequential principles to guide our antimicrobial program is to have the proper selection of the antimicrobial, starting with the accurate differential diagnosis that includes the likely bacterial infection. Even patient with bacterial infection treat only when the therapy will actually alter the clinical course of the patient. We have to start making our empirical treatment guidelines which are local, and there has to be a lower threshold for the critically ill patient. So you have to have a tier-based treatment policy of tier 1, tier 2, tier 3, and you have to look at the host factors that affect the antimicrobial stewardship program and the individual ASTs and the treatment also. The PKPD is very, very essential because many of the clinicians, they don't know what is antibiotic pathology, what sequence they have to give the antibiotic, what are what we call as the Y-site incompatibilities, that not to combine the concentration dependent antibiotics with the time dependent antibiotics. You have to learn and teach them, overcome the fear of de-escalation of the antibiotic. So, de-escalation. So starting an antibiotic is very simple. De-escalation and stopping the antibiotic is a very, very difficult aspect. That's why we have to rely a lot on biomarkers like CRP. So if the CRP is negative, then that means, or it's low, that's a sure short sign of stopping the antibiotic as early as possible. If the therapy is not working, we have to control it, we have to do source control. So in all our AST reports, we are always sending that the source has to be controlled first and then only the antibiotic, if required, to be given. And we have to distinguish what is the new infection versus the failure of the infection, and the duration should be evidence based. So the rule of thumb, or you can say the victim can be that for 3 days after the cessation of symptoms, systemic sign symptoms of the cessation of symptoms, you can control the antibiotic, but not beyond that. So there are numerous factors that are central to the management of the infectious disease syndrome, and all these factors have to be implemented for the successful implementation and the sustainability of a successful antimicrobial program. We have to focus on things like de-escalation, discontinuity of the antibiotics. We have to focus at what is the exact site of infection, the dose, duration of the antibiotic. We have to focus whether it's the only dose, focus on whether what is the correct antibiotic posology. We have to do source controls. All these factors, they are centric to the management of the infectious disease syndrome, and therefore. So, like I said, that we have to aim small, so we miss small. Don't go in for the everything at one time. You have to start with baby steps. So start small. Don't think that you can implement the AMS program in 1 day or 1 week or 1 year. If you take 3 years, 4 years, 5 years, you have to have patience. Nothing bad. So AMSP cannot be enforced. I'll just give you two of my own examples. So when I was first year PG, I did not have much clue about what is antimicrobial susceptibility testing, but I had a basic clue, that observation. So when I observed that Klebsiella pneumoniae is, so many isolates are coming from the neonatal ICU, all having the same antibiogram. So I visited on my own without informing my senior resident or faculty. I went straight away to the neonatal ICU and I spoke to the senior consultant physician over there, the neonatologist. Very, very senior person. I told him that this is the issue, something is coming from your neonatal ICU, there's something wrong. So he asked me, Beta, who are you? So I said, I'm first year PG from microbiology. So he said that you are the first person from microbiology in my career that has actually come the case with me or to discuss this with me. Otherwise, nobody comes. You only get reports, don't get anything. So this is something that nobody told me, but it comes from within. Like I said, it cannot be enforced, it comes from within. And it happens to automation. So every small step towards patient care is and the day of awakening, when a microbiologist starts perceiving himself as a clinician rather than a laboratorian or a diagnostic. So we are not just a lab branch, we are a clinical branch, and we need to observe ourselves like that if we want to truly rise as a clinical microbiologist and make a subject important. So we have to practice akarma. So coming back to the philosophical part, akarma means dissociating our actions with our ego and our expectations. So don't feel egoistic to go to the ward or go to the clinic, or you should not be egoistic that I don't know this. Yes, I don't know many aspects of microbiology. I've forgotten many of them. I have to learn. I need to learn. I can learn from a PG student. I can learn from my SRs. I can learn from my co-faculty. I can learn from the clinicians. I can learn from the patient. So you have to get over your ego, and you have to get over your expectation that yes, I have done this, so I will get this. No, you may not get the result, but you have to consistently do your work without any ego and expectations, and that is done. So both the sins and the good, everything is inside us only. We have to see what is the correct thing. So Devta and Dana both are inside us. So if you are feel proud of your branch, good. For the patient care, you can do it irrespective of what branch you are pursuing, whether you are pursuing a preclinical branch or a paraclinical branch or clinical branch, whatever that you're pursuing, you want to take care of the patient, you can do it because, like I said, and if you don't want, if you are always living in a complex or in a kind of a inferiority complex there, then you keep on thinking, oh, this is not a clinical branch, why did I do this branch? So, what we call as kuntha will always be there till the end of the career and will always end up being dissatisfied and not being contented. So, antimicrobial stewardship, this is a rate that antimicrobial stewardship gives you a choice whether you want surgical site infections or you want surgical strike infections. So that's my quote. That's Rai and his quote. That's and another one is that this antimicrobial stewardship, snakes and ladders. This is we have implemented in our institute. We show this as the last slide on all our lectures for undergraduates, so that while we are taking the attendance, this slide is projected on screen, and for 5 minutes while the attendance is being taken, the students can go through the slide and focus on what are the good and the bad antimicrobial stewardship practices. So another very interesting incident is from that movie Jurassic Park that says that God creates dinosaurs, God destroys dinosaurs, God creates man, man creates and abuses antibiotics, antibiotics create pan-drug-resistant bugs and viruses. So these bugs they kill man. Microbiologists, ID and IPC specialists inherit here. So be proud of being a clinical microbiologist. It is only your attitude and your dedication, devotion towards the subject that's going to bring a lot of greatness to the subject. It's a wonderful subject, be proud, and this attitudinal change will bring about the major shift in the implementation of the antimicrobial stewardship practices. With that, I thank all of you for the kind patience, and again apologies for not being able to attend to the meeting. Thank you so much. Jai Hind.
Appropriate justice for the topic by enlightening upon us the challenges that we face in the implementation of the antimicrobial stewardship program, starting right from the dedication of the microbiology to the challenges faced from the clinicians and the management side. He also said that the antimicrobial stewardship is a collective responsibility. It is not an individual who can bring about a change, but we need to work together on it, starting from the microbiologists to the clinicians, the management, and even the nurses have a great role to play in it. He also told us about the ways to overcome these challenges and the 10 commandments of how we can go ahead in implementing these antimicrobial stewardship programs. Very well said, sir. Thank you. And we welcome any questions to be put across to these online. Sir is there online. Sir also has very well had his experience of 6 government institutions in which he has worked and how he has taken across the antimicrobial stewardship in the current organization that he is working. It is a great learning experience from you. Thank you. Thank you. There we have a question from the hall.
Actually, as you said, the microbiology tries to take initiative and go to the clinic. Similarly, I think the clinicians also need to go to microbiology and discuss their issues with microbiology. Somehow, many of us are sitting in our silos. We have to break the silos and discuss these things so that the issues can be sorted out. Thank you. Good afternoon, sir. So nice to see you, sir. You've been principal in promoting antimicrobial stewardship in CNBC, and we have always looked upon you as one of the very microbiology friendly pediatric surgeons. And myself, also in a PhD in a pediatric hospital, I know how pediatric surgeons they rely so much on the reports from clinical microbiologists. I was actually looking forward to meet you, sir, but unfortunately I couldn't come to Hyderabad. But yes, in CNBC there has been a very good camaraderie between the clinical microbiologists and the pediatrics and the pediatric surgeons. And I think CNBC is one of the examples where you can say that there's a very good coordination between both the departments, and not just the clinical microbiology and pediatrics, but all the other pediatric departments. So thank you so much, sir, for your comment.
It's not the problem of clinician only or the lab people, microbiologists only. When we were interacting with the participants, microbiologists need some patient details to work on the test, reflect what needs to be done. And when we talk to the clinician, they say, why do they need this information? Just patient's name and ID, that should be enough. So I think fora like this, where everybody sits together and try to understand the problem each one of us is facing and try to find out how do we tackle this together. Unless we feel that we work together, this is not going to change. And something Sumit was again and again alluding to is this has to come from within. Just knowledge is not enough. We need to act on it, and small baby steps. You may say 10 strategies or actions are suggested. Even if in this hall full of people, if each one of you take one message, take home that I am going to correct this by one small intervention, like before drawing sample, we will not give antimicrobial dose. We'll give this dose after drawing sample. Just one small little intervention can make a lot of difference in the reporting and interpretation and the patient's outcome. So I think there is something for each one of us here. Something or the other is there. These 3 days are full of all those experiences, different strategies, interventions, the best practices, and if we can take home just one message, the purpose of G-SPARC will be done.
So, Dr. Sumit Rai, I came to your lab some time back, and we were just setting up the lab, and I was witness to the fact that it didn't come easy. You had to really, really work hard, get the equipment, and even before you got the equipment, you continue to use our age-old methods, manual methods. The key important thing was that the clinician got the information at time. The other big part that's missing here is our clinicians simply think that they just score their test. It's been a problem for me also to train my own trainees. You need to follow the microbiologist and ask what's the most appropriate way to get the specimen, what is the best way to make a diagnosis, what test should I use. As you know, we very often receive in the microbiology lab culture requests from an operative specimen that has been done to before me. So this is one of our key challenges in diagnostic stewardship, is to ensure that clinicians understand that if there is an error, 90% of the time if there's a pre-analytic error, it's not an analytic error, and the thing that gets screwed up very often is the post-analytic because of inadequate communication between the laboratory and the clinician. So kudos to Dr. Sumit Rai and my personal witness to how he's been doing this right work. Congratulations. Thank you so much.